Everyone, hope you're doing well. My name is Chen, and today I'll be taking you through some ophthalmology for the GP section of your exam this year. And I'll actually thank Cindy Liu and previous presenters from which I've derived this presentation. So for today, we'll be covering some general tips on how to approach the GP section of your exam, some core eye conditions, presentations, and the differentials. So specifically painful and painless red eye, sudden and gradual loss of vision, foreign body and trauma to the eye, and some PEDS as well. And you'll have some chance to do some optal questions in the in-person portion of the revision lectures a bit later on this year as well. So from the matrix, for ophthalmology, there are really only three R1 conditions, and those are conjunctivitis, blepharitis, glaucoma, ocular trauma, and foreign body. Everything else is really R2. But having said that, having done the exam from last year, there are like little things that may not be directly featured on the matrix here, but that were sort of talked through in the GP tutes, like those weekly Monday, Wednesday, like lectures and tutes you have. So I would actually highly recommend going through the content from that, from those materials again, to cover all bases, because some questions actually came from those areas and not directly on the matrix as well. For the PEDS section, these are not very high yield, but I'll just sort of quickly guide you through conjunctivitis in PEDS, orbital cellulitis, strabismus, retinoblastoma, and cataracts as well, to offer you like a more comprehensive idea going into the exam. So here are just some buzzwords that you can have a look at in your own time. So sort of the first thing I wanted to cover was an approach to the GP exam. So last year we had 16 marks on diagnosis, 8 on investigation, and 25 on management. So management is definitely the highlight, the biggest chunk of the exam. And I think it's really important to know for each presentation, so that's cough, chest pain, anything like that, which conditions are serious and urgent and should not be missed, and what are some specific symptoms that are red flags. So if you have that sort of down pat, it will make the management questions much easier, because in the management questions, they'll usually ask you like, oh, would you send this patient to the ED now? Would you consider referring them to a more specialized service now? Or would you sort of just see them in a week's time and to see how they're going? So if you know which conditions are serious and urgent and the red flag symptoms, you're more likely to be a safe doctor and manage the patient appropriately according to the options you're given. So this is very, very important for 4C. Having said that, I think it's really also important to revise your key core 3B conditions, and including their investigations and management. So make sure you revise how to read like a basic ECG, basic spirometry, like all the renal casts and things like that. They may be featured in your GP exam as well. Another thing to highlight is that there's a lot of images. So that's not really restricted to just opthal and derm. So you might get pictures from anywhere. And this might link to what I talked about before in terms of the management questions. And they might show you an image and you have to choose the correct management. So it's really important, for example, to be able to tell a quinsy apart from a viral pharyngitis, because a quinsy is much more urgent and will necessitate the patient being sent to the ED immediately. As an example, one other thing to know is the dosage of adrenaline. This is really important. I know this has been emphasized in your GP teaching as well, but make sure you know the dose for both adults and children. It is really, really high yield. Next point is that there might be some psych or NG and PEDS questions on your GP exam as well. I think they do a really good job selecting questions that represent sort of all of the subspecialties in your tutes and lectures during your GP rotation. So everything can potentially come up. And I actually found the past exams or Open Equala to be quite helpful in preparing for the GP exam. But I would say that our exam had a lot more management questions. So that's an area that I recommend you sort of spending some more time working on. So moving on to taking an opthal history. So With the history of presenting complaint, you always want to sort of really flesh out your WWQQ-AAA. For Optal specifically, you want to ask whether they have any previous episodes of, for example, the red eye or loss of vision. And you also want to ask whether the symptom is unilateral or bilateral on both eyes. With pain, so one key question is to ask whether the pain is worse at rest or when they move their eyes. If it's worse when moving their eyes, it's likely to indicate iritis and or scleritis. So that's really important to know. Whether the pain is sharp or dull and where exactly is the pain. Remember, some non-ophthal conditions can also have pain in the eye region. For example, cluster headaches can manifest as ventral orbital pain, so sort of pain behind the eyes, which might lead to some confusion as well. In terms of redness, you really want to sort of ask and have a look at which areas of the eye are inflamed. So is that just the conjunctiva? Is that sort of in the perilingual region? So the lingual region is basically where the cornea joins the sclera. And another sort of way to think about it is circumciliary. That's another way to describe perilingual. And also whether the inflammation is sectoral, so in only one part of the eye, or diffuse across the whole eye as well. For an ophthalmic history, you always want to ask about pain, photophobia, and blurred vision. These are just really, really important symptoms for you to ask, and will give you some more clues as to which which conditions the patient may have. You want to ask about discharge, visual changes, flashes and floaters, any foreign body sensation, any trauma to the eye specifically, any changes around the eye, in the eyelids, and the skin and lymph nodes as well. Importantly, for eye, you really want to think about the systemic conditions as well that may manifest in the eye. So I would always want to ask about, diabetes, cardiovascular disease, giant cell arthritis, which may be correlated with polymyalgia rheumatica, meningitis, and importantly, seronegative spondyloar arthropathies, like ankylosing spondylitis is an important one to ask because that can lead to anterior uveitis. One thing to always ask in ophthalmic history as well is whether they wear any contact lenses. So do they sleep with the hard contact lenses? Have they swam in them? Do they take a shower with them? And that's really indicative of a corneal ulcer, which we'll talk about later as well. Finally, for medication, some specific medications can have implications in the eyes. For example, if they use any steroids on the face, that can actually lead to earlier cataract formation, as well as contributing to the pathogenesis of glaucoma. And if they take any anticholinergic medications as well, that can potentially actually trigger an attack of acute angle closure glaucoma. So really important to ask about these things specifically. So with all of the GP presentations, I think for your apex, it's very helpful to sort of list down a few conditions and red flag symptoms that you should always ask. For most presentations, it's very easy. So just go through them systematically, and it will really help you to prepare for your apex, give you some more and sort of an anchor as you do your station as well. For eye specifically, so for red eye and loss of vision, so the urgent, serious, and not to miss conditions are those that are either sight threatening or life threatening. So you want to ask about stroke, TIA, or amaurosis fugax. So amaurosis fugax is a TIA of the eye. So it's a transient blindness in one of the eyes only. Another really important condition to always ask about is giant cell arteritis. So whether they had any jaw claudication or scalp tenderness. Remember, this is also associated with polymyalgia rheumatica. And if we have a younger patient presenting with, pain when moving their eyes, a relative afferent pupillary defect, or if they're unable to see red that well, we need to think about multiple sclerosis, and a manifestation of that is optic neuritis as well. Some other things that may come up in the exam is a bitemporal hemianopia, and I think this has been drilled into our minds in second year. But basically, if we have compression of the optic chiasm from a pituitary adenoma, that can lead to bitemporal hemianopia. So that adenoma may secrete prolactin. So that patient may also have symptoms like amenorrhea and galactorrhea, for example, or that adenoma may secrete, growth hormone leading to acromegaly, and may have implications in the thyroid and corticosteroid regulation in the body as well. And one just final thing on this slide is if someone has a PCA stroke or infarct, their sort of visual changes are a little bit unique. So they'll have an area in the central of their vision that's being spared. So that's macular sparing. And that's due to the fact that the macular region of the eye has two supplies. So one from the PCA, so the posterior cerebral artery, and one from the MCA, so the middle cerebral artery as well. So even if the PCA has infarcted, there'll be still a collateral blood supply from the MCA as well. So that's why we'll have a homogeneous hemianopia with macular sparing. Okay, so this is a very long set of differentials, but basically we'll be talking about painful red eye, painless red eye, vision loss, that's acute and gradual, and also foreign body and eye trauma as well, as per the matrix. So first up is painful red eye. So if it's painful, usually we want to consider an urgent referral to ophthalmology, and that's because the conditions that manifest this way are usually medical and ophthalmological emergencies. So these are things like, acute ankylosing glaucoma, corneal ulcers or keratitis, which is an infection of the cornea, iritis or anterior uveitis, which are the same thing, Scleritis, herpes zoster, ophthalmicus, and or any trauma and injury to the eye and endophthalmitis as well. For a painless red eye, it's less likely to be super urgent, and these are usually things like our subconjunctival hemorrhage, pterygium, and episcleritis, and conjunctivitis as well. But conjunctivitis can be painful or painless. And these are some of the key differentials from the associated signs and symptoms. If you're short on time, just go through like the buzzwords I showed before in this slide. So if they have a lot of discharge, think about bacterial conjunctivitis. If they have a lot of sort of photophobia, think about anterior uveitis and iritis, and also acute ankylosing glaucoma as well. If they have a lot of pain, that's a key symptom for acute ankylosing glaucoma. If they have a foreign body sensation, sort of grittiness and like an annoyance behind the eye, you might have to avert the eyelid and look at the area under the tarsus itself for any foreign body, or it might be just due to blepharitis, episcleritis, or scleritis. And if they have any swelling in the periorbital skin area, they might have a sty, a Chalazion, and or preseptal and or orbital cellulitis as well. So before we move on to acute ankylosing glaucoma, we'll just quickly revise the sort of basic pathophysiology behind aqueous humor regulation. So the eye is divided roughly into three chambers. We've got the anterior chamber, which goes from the front of the eye to where the iris is. So that's the anterior chamber. The posterior chamber is just behind that. So that's from sort of the iris to the lens is the posterior chamber. Behind the lens, we've got our vitreous chamber. So in the vitreous chamber, we've got our vitreous humor, which is a fluid that is gel-like. In the anterior and posterior chamber, the fluid is called aqueous humor. So basically what happens is that aqueous humor is being produced by a part of the ciliary body in the posterior chamber, okay? And then they'll actually flow to the anterior chamber and drain into the trabecular meshwork or Schlemm's canal as well. So as you might imagine, if there's any sort of obstruction in this pathway, it will mean that the aqueous humor will not be drained properly, and that can lead to increased intraocular pressure. So pressure will build up within the eye itself. And in acute ankylosing glaucoma, this is a medical emergency. The typical clinical vignette would be someone who is perhaps a middle-aged woman who is farsighted, and they present with sudden onset unilateral red eye and pain in the eye as well. And when you examine their eye, you might see a hazy cornea like that. And importantly, they may have a mid-dilated pupil. So in this image here on the bottom right, the left eye is actually the eye being affected because it is in a mid-dilated state. And that patient may have nausea and vomiting as well and photophobia. So one of the key sort of risk factors for acute angle closure glaucoma is that if they have hyperopia, so if they're far-sighted, and that basically means that the anterior chamber in these patients are much smaller, are much more shallower, um, and some medications can precipitate an attack as well. Most attacks actually appear when the patient have spent a little bit of time in a dark area. So basically what happens is that in the dark environment, our pupils will dilate, and then this can actually lead to the lens being stuck to the iris, and this can actually block the drainage pathway of aqueous humor, which can lead to a massive and dramatic increase in the intraocular pressure, leading to an acute angle closure glaucoma attack. So for investigations, the only thing that really needs to be done is if you can have access to a tonometer, you can actually measure the intraocular pressure of the patient. But the gold standard investigation is really ophthal started. It's called gonioscopy, which is like a specialized lens that can help you to visualize the anatomical structures involved in acute angle closure glaucoma. Usually, this is not performed in the GP setting. So in the GP setting, the most important thing to do is to refer the patient urgently to Opthal and make sure that they can get to the hospital in a safe manner. So, they probably won't be able to drive themselves because they will have really bad visual acuity. So, managing, if they have a partner or something to drive them to the hospital would be really, really important. The management for acute angle closure glaucoma can be remembered by STAMP. So S is making sure that they are in a supine position, so laying flat and avoiding further dilation of the pupil and making sure that not in a really dark room. So there's ambient lighting. Remember that dilation of the pupil is bad. In this condition, and leaving them in the dark will lead to the pupils dilating. So that's not good. And you also want to start them on some analgesia and antiemetics. So the T stands for timolol, which is a beta blocker that reduces the secretion of aqueous humor. You want to start them on acetazolamide or mannitol, which basically dehydrates the eye by draining all the fluid, which can help with decreasing the pressure. And you might give them some other medications like pilocarpine or dexamethasone as well. The definitive management is surgical. So basically, the ophthalmologist in the clinic will use something called laser iridotomy, basically creating a little hole in a trabecular meshwork using a laser, which is pretty cool. So the next sort of few conditions that I'll talk about are related to cornea. So just a brief sort of idea of the cornea. It's in the anterior part of the eye. It has a protective effect of the rest of the eye, and it has 5 layers. So it has the epithelium, the Bowman's layer, the stroma, the Deschamets membrane, and the endothelium. So the first condition that's related to the cornea is corneal abrasion. So basically, this is when there's a defect in the corneal epithelium, which is the most superficial layer of the cornea. And the typical sort of clinical vignette you'll get is maybe like a gardener will come in and then they might have like a little branch falling into their eye. And due to, repetitive blinking and rubbing of their eye, the little branch has sort of caused a few abrasions in the epithelium of their cornea. So some other predisposing factors to corneal abrasions include corneal exposure due to them having dry eyes or a facial nerve palsy. So if they have a facial nerve palsy, they may be unable to fully close their eyes. So that will lead to more dry eye symptoms as well. If they wear contact lenses or have diabetes, those are really important predisposing factors as well. So the key symptoms is that they'll have a really stabbing pain, a red eye, and a corneal abrasion is usually unilateral. So basically for management, you will like to sort of see them in clinic every day until the abrasion sort of heals back. So the cornea actually has a remarkable healing ability. It usually will clear the abrasion by itself and fully heal by about 2 days. But you really want to see the patient every day. Until it's fully healed. And if it doesn't get better, there's room for sort of referral to ophthalmology. You would like to sort of prescribe antibiotic ointment, chloramphenicol is an option, and you would like to sort of give them some some analgesia as well to help with the pain, and some ocular lubricants for symptomatic relief as well. So the next condition is an corneal ulcer or keratitis, which we'll talk about in the next slide. So this is a little bit worse than an abrasion. This is getting through to a deeper layer of the cornea, and it develops over days. So the symptoms are pretty similar. So you have a red eye, photophobia, decreased visual acuity, and you'll have progressive eye pain. And if you actually look at their eye on the slit lamp, you might actually stain their eye using fluorescein stain, and it'll show some disruptions of the cornea itself. You might see some corneal infiltrates as well, but this is not always possible in the GP setting. This is a very, very important condition that's potentially sight-threatening. So you'll want to refer them to Opthal urgently and also perform a corneal scraping for microscopy culture and sensitivity to direct future antibiotic treatment. You do not really want to give them any local anesthetics, which can stop the healing of the ulcer and it can impede on the healing process. And really, really importantly, this is where the contact lenses will come back. So the contact lenses are a key risk factor for developing corneal ulcers and keratitis. And as I said before, like if they wore them for a really long time, if they swam in them, if they took a shower with their hard contact lenses, that's a really big risk factor for developing a corneal ulcer. And the specific pathogen that's related to that is Pseudomonas, which is a really nasty bug. So moving on to microbial keratitis. So microbial keratitis can be caused by a host of different infective agents. So it can be viral, it can be caused by fungal and amoebic causes and bacterial. But all of them will have photophobia, pain, and some edema on the eyelids as well. The key risk factor is just injury to the cornea, as you might imagine. And again, this is where the contact lens wearers come in, being a at-risk group for this condition as well. And if they have any sort of decreased immunity that's localized to the ocular surface, or if the ocular surface is compromised, for example, in patients with diabetes or someone with like an abrasion on the cornea, as we talked about before, that is a very important risk factor for microbial keratitis. So basically what you want to do for management is, again, arrange for acute ophthalmology assessment within 1 or 2 days. You may want to consider doing a corneal scraping if it's bacterial or fungal. For the management themselves, for bacterial keratitis, you want to use ciprofloxacin. This is different to most of the other bacterial infections of the eye, which uses chloramphenicol, and that's because Cipro is very effective against Pseudomonas, and Pseudomonas is implicated a lot in microbial keratitis, especially in those who wear contact lenses. And you just will make sure that they won't be able to drive and making sure they don't put the dirty contact lenses back in as well, which is really important. So for viral, the most important cause for keratitis is herpes simplex virus, and the most common pathogen is HSV type 1. So if it helps you to remember, if the infection is above the waist, it's most likely going to be HSV1. If it's below the waist, it's more likely to be HSV2. Past history is important because they may have had similar episodes before, because herpes simplex keratitis is a recurrent. The most sort of telltale sign for this condition is that if you have a look at their eye, And if you do fluorescein staining, you'll see this classic dendritic pattern. And you may also, when you do cotton wisp test, they might have a decreased corneal sensation as well. So these are very important features for herpes simplex keratitis. Usually, it's fine if you just treat them in the GP setting. So the first line is topical acyclovir and antiviral, and you can actually take a HSV PCR swab to confirm the diagnosis as well. Um, if they don't get better, or if on presentation you see that their vision is quite bad, and if there's visible corneal opacity sort of deeper in the cornea, you'll need to refer them urgently to ophthalmology. So it can be a bit confusing because herpes simplex is caused by HSV, but herpes zoster ophthalmicus is caused by varicella zoster. Um, so it can be a little bit confusing. So herpes zoster ophthalmicus is essentially when people have chickenpox, and then the VSV virus becomes latent and dormant in the trigeminal ganglion. And later in life, for whatever reason, it might reactivate through the first branch of the trigeminal nerve, which is the ophthalmic branch. So V1 is the first branch of the trigeminal nerve, and it can lead to pain and rash within that nerve. And importantly, there's a sign called Hutchinson's sign. So basically, if you see any vesicles on the tip of the nose, that means that there is nasociliary nerve involvement. A nasociliary nerve is a branch of the V1 nerve. And basically, that means that there's a higher risk of ocular involvement in that patient, and you should have more frequent follow-ups with that patient. So, some of the important things for this condition is that it is very likely to be causing iritis and keratitis, which can be potentially sight-threatening. And also, just like shingles, it is likely to cause postherpetic neuralgia as well, which can be quite debilitating for patients who experience chronic pain after VSV infections and reactivations. For management, it's an urgent ophthal referral. It's a very serious condition, and you would like to support them by just fluids and analgesia and topical lubricants as well. Um, but the mainstay treatment would be pharmacological. So you would like to start them on oral antivirals within 72 hours of rash onset for about a week's time. And this is very similar to the treatment for shingles as well. So just keep this in mind because shingles is very likely to come up in the GP exam. Um, and just a little quick summary. So we did cover a lot of types of keratitis. So for the management of bacterial keratitis, we choose Cipro, which is effective against Pseudomonas. For herpes simplex, it's an ointment or topical acyclovir, an antiviral. And for herpes zoster, which is caused by varicella zoster, we want to start them on oral antivirals just because this one is a little bit more severe. It can be sight-threatening, and there's also the risk of postherpetic neuralgia as well. So that's why we do oral and not just topical. Okay, moving on to the next topic, which is iritis and anterior uveitis, which is the same thing. So the uvea tract or the uvea is a little bit elusive. Basically, just means the iris, ciliary body, and choroid, and it's called the uveal tract because I think in Latin or whatever language, uvea means like grape, and when you do dissections of the eye, the uveal tract is a deep purple color. So that's why it's called the uveal tract. Um, and the anterior part of the uveal tract, the first part is the iris and half of the ciliary body. So that's where the name sort of anterior uveitis came about and just means the same thing as iritis. So the etiology for this condition can be infectious, but most commonly it is autoimmune. So it's associated with the HLA-B27 diseases, which are ankylosing spondylitis, psoriatic arthritis, inflammatory bowel disease, and reactive arthritis, and juvenile idiopathic arthritis may be implicated as well. Important to know that it is not associated with rheumatoid arthritis. So when you see an image of the eye, the most important thing is that you'll see an irregular shaped pupil, which may be myotic as well. Basically, this is called a posterior synechiae. So due to all of that inflammation at the back of the eye, there's, you know, a lot of inflammatory mediators running around and everything becomes a little bit more sticky. So when the iris sticks to the cornea and or the lens, it can actually sort of distort the shape of the pupil, leading to a posterior synechiae. And you may also have some redness and perilimbal injections as well. So remember, the limbus is where the cornea joins the sclera. So this is basically the perilimbal region, and you might have redness in this area. And another name for that is circumcorneal injection as well. Patients who have iritis may also have reduced visual acuity, and you might see a hypopyon when you examine their eye as well. So a hypopyon is basically a collection of pus and cellular debris that's accumulated in the anterior chamber, and just due to gravity, they all sort of fall to the bottom. So that's why it's called a hypopyon. So for this condition, again, it's an urgent opthal referral, preferably on the same day. And the opthal team will probably start on topical steroids to reduce the ocular inflammation. And they may also start them on a topical mydriatic condition. So that's either cyclopentolate or atropine. Basically, what these medications do is that they'll dilate the pupil, which will break down the adhesions, creating that posterior synechiae, and this relieves pain as well. And you may also give them some oral NSAIDs. So just one thing to remember, in acute angle closure glaucoma, you don't want pupil dilation because that makes the attack worse. But for iritis and anterior uveitis, you want to dilate that pupil to break down the posterior synechiae. So it's very important to sort of differentiate the two. The next condition is endophthalmitis. Basically, if your patient has had an eye surgery in the past, or if they have a systemic bacteremia or a systemic candida infection, they may get endophthalmitis, which is an infection of the aqueous humor plus or minus the vitreous humor themselves. You'll see quite extensive purulent discharge as well as a very large hyperpion. And if you see this, it's an urgent opthal referral, and they may actually inject antibiotics directly into the vitreous chamber as well. So, the next conditions are orbital cellulitis and preseptal cellulitis, and this is in the PEDS matrix. So it's really, really important to know. The etiology for orbital cellulitis is usually if they have an inflammation or infection of the ethmoid air cells, or if they have an infection of the sinus, it can actually travel up and affect the orbital area as well. And this is really, really a severe and urgent condition because it can lead to brain abscesses and meningitis. And therefore, this is an urgent hospital referral. So they will need to be admitted, and then you'll need to give them some IV antibiotics. Before that, you'll like to take their blood culture and also perform a CT scan of the orbits and sinuses just to see how far the infection has gone. So this is a medical emergency, orbital cellulitis. For preseptal cellulitis, it's usually a little bit milder. It's usually caused by some localized trauma in the skin area around the eye. So that can be due to, a scratch or an insect bite, for example. And usually you'll just give them some antibiotics orally, so it's not as severe as orbital cellulitis. The key differentiating factor between these two is that orbital cellulitis will have painful and restricted eye movements and abnormal vision, so decreased visual acuity, whereas preseptal cellulitis will have normal eye movements and visual acuity. So when you do the H test, this is one of the best tests to immediately tell whether they have orbital cellulitis, which you need to admit them and give them urgent IV antibiotics, or preseptal cellulitis, which you can just send them off home with some oral antibiotics. So it's really important to know how to differentiate between these two. The sort of clinical signs is the most important. So always test normal eye movements. So having a fever doesn't really differentiate between the two, and the appearance can be quite similar as well if you just look at them, if you just do general inspection. The next conditions are scleritis and episcleritis. So the sclera is a very dense, continuous fibrous tissue around the eye itself. The episclera is a more smooth connective tissue just on the outside of the sclera under the conjunctiva. So the key thing with these two is that episcleritis is generally less painful, not really associated with any systemic disease, whereas scleritis can be extremely painful and is usually associated with rheumatoid arthritis. One other important differentiating factor between the two is that episcleritis will blanch with 10% phenephrine, and this medication is an alpha-1 agonist to constrict the blood vessels. So episcleritis will blanch, as you can see in the image here, but scleritis will not. And here's just another sort of table to help you differentiate between scleritis and episcleritis, which you can have a look at in your own time. So the next few conditions relate to the conjunctiva. So just a little bit about what the conjunctiva is. It is a thin, clear mucous membrane that lines the inside of the eyelids and covers the sclera up to the edge of the cornea itself. And it has some important roles in protection of the eye and lubrication as well. So there are three main types of conjunctivitis. There's viral, bacterial, and allergic. And it's really important to be able to differentiate between these two subtypes. So remember, conjunctivitis is one of the only R1s in ophthalmology. It's good to have a really good understanding of this condition. So for viral conjunctivitis, usually it starts in one eye, and due to like rubbing and whatever, of the other eye, it will be able to spread to the other eye as well. It's a very common condition. The discharge is watery, shouldn't see any sort of mucus there, and it is associated with preauricular lymphadenopathy. So that's a very important clinical sign that's associated with viral conjunctivitis. For the management, it's mainly just supportive, so lubrication and also doing some cold presses as well. For bacterial conjunctivitis, the really important sign is you'll have a purulent discharge, and sometimes the discharge will stick the eyelashes together, and then the patient will start the day not really able to open their eyes. So that's a very important sign for bacterial conjunctivitis. And for treatment, our good friend chloramphenicol is here again. And just a little reminder, so for chloramphenicol, one of the key and really important severe side effects is actually aplastic anemia. So just in case that comes up. The last type of conjunctivitis is allergic conjunctivitis. It is bilateral. The eye is described to have a watery, glassy appearance, and it's usually seasonal. So for allergic conjunctivitis management, we'll be thinking about topical and oral antihistamines. And I've just have some more information on each of the three types in the slides, so feel free to have a look in your own time as well. So we'll be moving on to painless reactor eyes now. So one of the conditions we need to think about is subconjunctival hemorrhage. It looks really bad. There's literally blood in the eye itself. So it's due to a rupture of a conjunctival or episcleral blood vessel causing bleeding into the subconjunctival space. And these are usually patients who are coughing a lot. So they may have asthma or COPD. They may be straining due to constipation, or for patients undergoing labor as well. It's very, very common to have a subconjunctival hemorrhage. So even though it looks really bad, it usually just spontaneously self-resolves within 1 to 2 weeks, and there's not really much that needs to be done for both the GP and or the ophthalmologist. And it is just really important to keep in mind that even though it looks bad, it doesn't really harm the patient. So you can just leave them be and educate them about lubrication and some supportive strategies. Another condition is a pterygium. So basically, this is a wing-shaped gradual fibrovascular growth from the bulbar conjunctiva. And it's called surface eye because surface, they have a lot of exposure to the sun, to the wind, to the dust and sand as well. And these are all risk factors for the development of pterygium. The management is just UV protection and some ocular lubrication for symptomatic relief. And if they have a pterygium that grows over the cornea, and that affects the way they see, that's sort of obstructing the visual axis, then a surgical input is definitely warranted as well. So another condition that looks quite similar is a pincocula, and this has no corneal involvement. It just sort of stays outside the cornea, and it actually does not grow into pterygium. These are two different pathologies. Next up is blepharitis, which is a chronic inflammation of the eyelid margins, and it can be associated with a lot of the derm conditions. So the most important ones are seborrheic dermatitis and acne rosacea. So in the exam, if you see like a rhinophyma or something, then you have to think about acne rosacea, and that's actually linked to blepharitis as well. So there are two main types of blepharitis. There's anterior blepharitis and posterior blepharitis. So anterior is usually caused by a bacterial infection, or it can also be caused by seborrheic dermatitis. A posterior blepharitis is usually caused by a meibomian gland dysfunction. So either way, for both conditions, the mainstay management is just eyelid hygiene. So that's daily warm compresses, and using some baby shampoo as well, and making sure to avoid makeup and contact lenses that can irritate the area even further, and potentially consider some ocular lubrication as well if the patient also complains of dry eyes. If the blepharitis is really severe, you may consider adding some antibiotics. So for anterior, you might add some topical chloramphenicol, and for posterior, you might add some oral tetracycline. So the tetracycline in this case is not really about killing the bacteria per se. It just will change the composition of the oils and making it less likely to obstruct and cause blepharitis. Some quick notes on entropion, ectropion, and trichiasis. So entropion is when the eyelids are turned inwards. Ectropion is when the lower eyelids are being inverted, so the eyelids are turning outwards. And trichiasis is when the lid is in a normal position, but the eyelashes are not, and the eyelashes are facing sort of towards the eye itself. It is very common for patients who have had trachoma, which is more common in the Aboriginal and Torres Strait Islander origins and communities of Australia. And as you might imagine, so if the eyelids are sort of facing inwards, every time they blink and open their eye, they may have some micro trauma to the cornea itself. And over time, this can accumulate, and they may actually have some sort of vision loss and blindness just from that trauma as well. So next up is Chalazion and hordeolum. So these are both sort of eyelid swellings. A chalazion is a sterile meibomian gland obstruction, whereas a hordeolum, also known as a stye, is usually due to an infection caused by Staphylococcus aureus. And the key differentiating factor between the two is that hordeolums are painful. So you can use the mnemonic hordeolums hurt to help you remember, and chalazions are painless, so they don't hurt. For management, they're quite similar. So you'll start with conservative management with warm compresses up to 4 times daily, and gentle massaging and hand washing as well. If nothing really works, you will consider incision and drainage for both chalazion and hordeolums as well. Okay, so the next few sort of conditions relate to the retina. So the retina is at the back of the eye. It converts the light we see into the images. So it has a really, really important function in our vision. And we'll be covering sudden and gradual loss of vision. for this lecture. So for sudden loss of vision, we can classify them into three main sort of categories. So disorders of the eye themselves. So acute ankylosing glaucoma, retinal detachment, wet macular degeneration, and vitreous hemorrhage. Another category is the vascular disorders. So these are things like retinal artery or vein occlusion, amaurosis fugax, and giant cell arteritis, and also disorders that directly affect the optic nerve. The most important one is optic neuritis. There are some other sort of miscellaneous classifications. So intracranial causes like a stroke, migraine, or space-occupying lesion can also cause sudden loss of vision, endophthalmitis and trauma as well. And some drugs such as amiodarone and chloroquine can also lead to changes in the vision, and diabetic retinopathy and thyroid eye diseases are important factors to consider as well. So on the other side of the spectrum, we have gradual loss of vision. And again, we can sort of differentiate them between disorders of the eye and more systemic disorders. So for disorders of the eye, we're really thinking about cataracts, primary open glaucoma, dry age-related macular degeneration, and refractive errors. For systemic, we're thinking about diabetic retinopathy, hypertensive retinopathy, and some more like rare cases of cancer as well. So the first condition we're going to talk about is retinal detachment. So there are 10 layers of the retina. We have the inner retina and the outer retina. So basically, retinal detachment is the detachment of the neurosensory layer from the retinal pigment epithelium, which is the outermost layer of the retina. There are three main types of retinal detachment. There's retinotogenous, which is usually caused by a tear in the retina. And if you think about it, the retina is in direct contact with the vitreous humor. So the humor can leak in and accumulate beneath the retina, causing it to detach. And the main culprits are increasing age and past ophthalmic surgery. The second type is tractional. Basically, this is due to neovascularization of the retina itself, and the main culprit for this one is diabetic retinopathy. And our final type is exudative. This is when there's an accumulation of fluid beneath the retina in the absence of retinal tears, and the main culprit for this one is malignancy and cancers. So the patient would usually complain of seeing some flashes of light and floaters in the prodrome, and when the retina starts to detach, actually, and there will be a sudden painless loss of vision in the affected eye, and the patient would usually describe it as a curtain descending over their field of vision. So just a brief recap and some important images. If you see this sort of appearance on fundoscopy, then it is indicative of a retinal detachment. You can see the retina is actually detaching from itself. Okay, so for the management, you would want to have an urgent ophthalmology referral, and they'll do some specific surgical management. The complications for retinal detachment is permanent blindness, some sorts of uveitis, and retinal detachment to the other eye as well. So it's really important to get on board with that. Um, Another condition is called posterior vitreous detachment. Basically, this is the detachment of the posterior vitreous, which is a gel-like substance from the retina itself. The risk factors are very similar to retinal detachment. So this is increasing age, ocular trauma, ocular surgeries in the past, and if they have myopia. Symptoms are very similar, so flashes and floaters. But the only thing is that a PVD is a common and usually it's benign, so it doesn't really become retinal detachment. And a PVD will most likely to resolve over time. So you just need to educate the patient and letting them know the like potential signs for retinal detachment. So if they see like a curtain coming down their eye, then they'll need to go to the hospital immediately, preferably having someone else driving them there. Another condition is vitreous hemorrhage. Basically, that's when there's a leakage of blood into the vitreous itself. And the key thing here is to think about the condition that cause neorevascularization, so that building up of the blood vessels, the leaking and the bleeding of those vessels. So the main culprit is usually, again, proliferative diabetic retinopathy. For this condition, there's a sudden painless loss of vision, and you'll see some flashes and floaters as well. Um, and importantly, you can also do some more specialized tests. So you can do some fluorescein angiography or CT scans, but this is sort of beyond what would happen in the GP clinic. For the so for the management, very important for urgent ophthalmology referral, and they might start on some anti-VEGF injections to reduce the neovascularization, which triggers the leakage and bleeding in the first place. And there are some specialized surgical management options as well. So moving on to giant cell arteritis, this is a very, very important condition. Basically, a giant cell arteritis is caused by the inflammation in the wall of medium to large arteries, and it usually happens in patients who are over the age of 50 and those who have polymyalgia rheumatica. Some of the key questions, like your cluster questions, should include, a headache, scalp tenderness, jaw claudication, and the condition is quite serious because it can lead to total blindness and aortic aneurysm as its complications as well. So basically, the key management is that if they already present with visual loss or have a history of transient visual loss, you'll want to refer them acutely to the room team for temporal biopsy and IV methylprednisolone, which is really, really important to get the inflammation under control. Otherwise, the team might start them with oral antibiotics and consider temporal biopsy as well. Okay, next conditions we'll just quickly gloss over. So we have amaurosis fugax, which is basically a TIA of the eye. It's only causing transient vision loss lasting seconds to minutes, like a pattern passing across their eye. But this is very important because it might be increasing the risk of that patient to having a stroke. So you want to rule out stroke immediately, and you would investigate them as having a high risk of stroke. And basically, you also be targeting the metabolic profile of that patient as well to prevent further risks in the future. So moving on to optic neuritis. This is an inflammation of the optic nerve itself. It's most common in younger women, and it is associated with multiple sclerosis. So basically, the patients might present with some sort of isolated eye symptom, like a painful eye movement. They might see double, they may have an enlarged blind spot, and they may have red color vision loss, for example. And for the management, just think about MS management. So you need a neuro team, and then you can think about doing some IV high-dose steroids as well. Yeah, so for the vascular causes of vision loss, the two main differential diagnoses we're looking at are retinal vein occlusion and retinal artery occlusion. So starting with retinal vein occlusion, it is sort of described usually as a blood and thunder appearance on fundoscopy, or another way to think about it is a stormy sunset. It looks really angry with a lot of tortuous veins, dot blot hemorrhages, and cotton wool spots as well. This is a condition that requires opthal referral, but it's not as urgent. So the opthal team might consider laser photocoagulation or anti-VEGFs in the long term. And importantly, this condition may lead to complications such as glaucoma in sort of 2 or 3 months' time after it has resolved. On the other hand, we've got retinal artery occlusion, and on fundoscopy, we have this classic cherry red spot at the fovea region, and this is due to the choroidal vessels. Importantly, this is an urgent medical emergency, so the retina can only sort of survive for about 90 to 120 minutes in ischemic conditions. After that, they're gone. So we need an immediate, urgent, emergency ophthal referral, and we need to arrange transport for the patient as well to salvage the retina. And here's some more information if you'd like to know more about retinal artery occlusion and retinal vein occlusion. So now we'll be changing gears to talking about gradual vision loss, and then we're almost there. So the first condition in this category is age-related macular degeneration, which can be subdivided into dry and wet. So 90% of those with ARMD are having dry macular degeneration. And basically, they will have some drusen deposited under the retinal pigments, which can lead to ischemia of the outer parts of the retina. And it is asymptomatic in the early diseases. And whereas for wet macular degeneration, it only contributes to about 10%. It is usually unilateral, and there's a growth of abnormal vessels called choroidal neovascularization under the retina that can leak and bleed and lead to further neovascularizations, progressing ultimately to an untreatable fibrotic scar. So this is a really, really important differential to keep in mind. Looking at the two different types of age-related macular degeneration. So for dry AMD, we have some drusen being deposited under the retina itself. And the sort of end stage of dry AMD is called geographic atrophy. For wet AMD, it's due to the leakage and bleeding of those new blood vessels. So we may see some more fluid, some more edema, and some more subretinal hemorrhages as well. So the hemorrhages, the fluid, is really the sign that can help you to differentiate between wet and dry AMD. So if someone has wet age-related macular degeneration, it is an urgent ophthalmology referral if they have sudden and rapidly progressing vision loss. For wet age-related macular degeneration, it is treated by the ophthalmology team with anti-VEGF injections and or laser photocoagulation or intravitreal injection of such an agent. For dry macular degeneration, there's not much that can be done, and there's not really any treatment that is effective. So we just monitor these patients longitudinally. So they'll have annual examination by the optometrist. They'll self-monitor weekly with the Amsler grid as well, which we talked about at the very start of this lecture. So the next condition is primary open-angle glaucoma. So for this condition, they may have increased intraocular pressure, but they may also have a normal intraocular pressure. So this is a bit tricky. Basically, what happens is that the visual loss will start peripherally and then will creeping more centrally as the disease progresses. And this is due to an increased resistance in the trabecular meshwork, leading to a decrease in the drainage of the aqueous humor, which can lead to a rise in intraocular pressure, but a bit slower than what you might expect from acute angle closure glaucoma. So for the management, really the IRP is the only modifiable risk factor we have. So all of the medications sort of try to reduce the IRP. So you might start with a topical medication, so maybe a topical prostaglandin analog, and then you might plus another agent. And you really want to try to avoid steroids, which can lead to increased intraocular pressure and contribute to the pathogenesis of glaucoma in the first place. The next one is cataracts. So cataracts is a very broad, a sort of heterogeneous cause of opacification of the lenses. 90% of cataracts are in older people. The rest are in neonates due to a range of different genetic and metabolic conditions. So there's a range of different appearances of cataracts caused by different factors like trauma, radiation therapy, diabetic Cataracts can look like a snowflake. Wilson's disease can cause a green sunflower appearance on the cataracts. And some congenital infections, like congenital rubella, is a very well-known cause of cataracts in the newborns as well. So the patients might complain that they have gradual visual loss, and they may have blurring and smudgy vision despite recent glasses change. So that really shouts out to you that it's not really a refractive error. And they may have some glare from daylight. They might have trouble with night driving due to halos. They might have a progressive yellowing of the colors due to the cataract. And remember, it is painless, so it's a little bit harder for patients to perceive this change, especially if they chronically get used to it and just blame sort of on the refractive errors. So for management, usually we just monitor them for um, longitudinal changes. So you want to refer them to an optometrist to check whether their loss of vision is due to a refractive error. Avoiding smoking and sunlight overexposure can help with the management as well. And the mainstay management is just surgical. The technique is called phacoemulsification, and this is done by the ophthalmologist. So refractive errors is also on the matrix. So the four main types are myopia, which means they're short-sighted, hypermetropia, which means they're far-sighted, presbyopia, which is very similar to hypermetropia, but this happens when basically from the age 40 onwards, the lens in the eye become progressively unable to accommodate, and this makes it very hard for patients to read. Um, and this condition happens bilaterally as well. So presbyopia is a very common and important condition that affects basically everyone growing older. And the final class is astigmatism. Basically, this is when the cornea shape and or lens is abnormal and not perfectly spherical. So you might actually have an uneven curvature of the eye, leading to irregular focusing of the light, and the images might focus on multiple points on the retina, leading to really blurry vision. So quickly, we'll gloss over diabetic retinopathy. So there are two main manifestations, which are non-proliferative and proliferative. So for non-proliferative, you might see like microaneurysm, dot blot hemorrhages, cotton wool spots, heart exudates, and edema. And for proliferative, you might see some vitreous hemorrhage and retinal detachment. Remember, it's one of the key causes for tractional retinal detachment. And for management, you'll consider the ophthalmologist team will consider intravitreal anti-VEGF injections and or PRP as well, which can have this appearance when you look at their eye using fundoscopy. We also have hypertensive retinopathy. So this is manifesting in sort of different clinical findings compared to diabetic retinopathy. So you might see some more like AV nicking, some more areola narrowing, some more copper wiring, and generalized areola narrowing. So these are more like signs that are associated with hypertensive retinopathy than diabetic retinopathy. And we won't really cover retinitis pigmentosa and neoplasia. So finally, we have foreign body and trauma in the eye. So for foreign body and trauma in the eye, you really want to think about like on history, whether they have pain on blinking, and if they do, whether the foreign body is on the cornea itself or whether it may be under the tarsus if it's not visible directly on the cornea. And again, you need to think about the infection risk, whether they have those risk factors like wearing contact lenses, if they're a gardener with like a little branch in their eye, whether they have diabetes, which can lead to localized immuno sort of suppression in that area and making it more likely to have an infection. And you need to exclude a penetrating injury to the eye. So that's a high impact mechanism that can lead to decreased visual acuity. And if you suspect that they do indeed have a penetrating injury, do not continue your examination. This is very important, and urgently refer them to ophthalmology in the hospital. So for the management, so if you think that a more specialized team is better at taking care of the patient, then definitely refer them to ophthalmology urgently. Otherwise, you can just sort of give the eye a little bit of a local anesthetic and then use a 18 or 20 gauge needle to loosen the foreign body and or use in a dental burr as well. And afterwards, you want to make sure that you give them chloramphenicol to sort of manage any potential infection, like microbes entered into the cornea through your treatment. Um, and it's really important to know that for a child, if the foreign body is central and it looks deep or penetrating, then you need an urgent referral. And this is not something that should be done in the GP setting. For a chemical injury to the eye, the most important thing is to irrigate, irrigate, and irrigate. So keep irrigating for about at least 15 minutes, and then you can continue testing the pH of the eye until it becomes normal. So the key thing is to irrigate. Um, and then you can also give them some local anesthetics as well if they have a very high pain level from the injury itself. And after irrigation, you will want to, so as you irrigate as well, you'll like to refer them to the opthal team. And once they're in the hospital, you want to sort of examine the eye. So you want to evert their eyelid to see if there's any particular matter in the conjunctiva itself. You want to sort of look at the cornea to see if there's any hazes or epithelial defects. You want to have a look at the conjunctiva and as well as if there's any limbal ischemia as well. So we'll just finish off by talking a little bit about some of the PEDS conditions. So ophthalmia neonatorum is basically when a baby has bilateral conjunctivitis and they have to be less than 30 days old, usually caused by things like streptococcus, staphylococcus, haemophilus, chlamydia, and gonorrhea. The timeline may be important. So in the first 24 hours of life, if they have chronic discharges from the eye, it is most likely due to like chemical. And if it's within the first few days, it's most likely Neisseria gonorrhea because that's hyperacute. If it's sort of within a week to 2 weeks, it's more likely to be chlamydia and or herpes. And there's different sort of management guidelines for ophthalmia neonatorum, and depending on the pathogen itself. So, for example, for gonococcal conjunctivitis, a stat dose of ceftriaxone is needed. And if it's suspected to be chlamydial, then oral erythromycin is sufficient. Um, an R3 condition is retinoblastoma. Basically, that's a malignant tumor of the retina. It is caused when there are two mutations on the tumor suppressor gene called RB. So 40% of retinoblastoma is autosomal dominant, and the other ones are spontaneous. And the heritable ones are usually bilateral, so they have bilateral retinoblastoma. The spontaneous mutations are unilateral. Some of the things that you want to have a look at is when you do the red eye reflex, which you should do as a normal baby check anyways, you'll see a leukocoria, so you'll see a white eye. And the management is just referral to ophthalmology with oncology input. So for cataracts, this can also happen to a child in the pediatric setting. So it's a very important cause of leukocoria, which is a white eye. So the main etiology are either hereditary And if they are most likely going to be autosomal dominant. Some congenital infections can also lead to cataracts. So the classic triad of congenital rubella is actually a patent ductus arteriosus, microcephaly, and also cataracts. So I think this is a good triad to try to remember. Some metabolic conditions like galactosemia, trauma, radiation as well. So amblyopia is a little bit complicated. So basically, the children's visual axis will develop until when they're about 8 to 9 years old. So before that, if there's any deprivation of stimulus, if they have an uncorrected refractive error or uncorrected strabismus, it can actually lead to one eye being used much more than the other eye. And it's bad for the eye that's not being used much because it's unable to get all the stimulus to develop its functions. So to manage this, again, optal referral, and then you can actually put a patch or atropine on the good eye, so the bad eye has a chance to catch up as well. For strabismus, so basically this can either be a vertical or horizontal misalignment of the two eyes. So when the eye is turning inwards, we call that esotropia. When they're turning outwards, we call them exotropia. If it's downwards turning, it's hypertropic, and if it's upwards turning, it's hypertropic. There are two main types of strabismus. So there's tropia and phoria. So tropia is when the misalignment is always there, but phoria is only when you sort of break the fusion of the two eyes. We don't really need to go into too much detail, but the management is just they need referral and surgical management. Just a final slide on eye movements. So if you remember, the lateral rectus is innervated by cranial nerve 6, and that does abduction. So if you have a cranial 6 weakness or palsy, then abduction is going to be affected. Um, the other muscle that's really important to highlight is the superior oblique, which is innervated by cranial nerve 4, the trochlear nerve, and it does a range of functions like depression, abduction, and intorsion. All the other extraocular muscles are affected and innervated by cranial nerve number 3. So if you think about it, if you have a cranial nerve 3 palsy, cranial nerve 6 and 4 are still unaffected. So that can lead to too much abduction, okay, too much depression and too much intorsion, leading to the down and out picture that you may have heard about before. So actually, like just brushing up on the anatomy can help you to think about these classical signs as well. So I know that was a really, really long talk, and hopefully it's helpful in your revision. Always let me know if you have any questions, and I'll try my best to help in whatever way I can. In this busy assessment season, make sure to look after yourself, and yeah, feel free to reach out to me if you need any clarification or any support as well. Yeah, good luck.